Let me introduce Professor Dr. Svitlana Koval from the United States, and the topic for today's presentation is direct printed aligners in conjunction with midfacial skeletal development procedures.
Yes, can you?
Thank you, Doctor, so much for your contribution and for your presentation as well.
Thank you. I'm trying to find the screen. I'm very honored to present today with the topic of the midfacial skeletal expansion and the use of 3D printed aligners. And I do not have any monetary benefits or any reimbursements from the companies or the software I'm using. A little bit about myself. I'm the owner of the airway-oriented practice, the airway specialty practice in orthodontic practice in Boca Raton. The book on T-scan digital occlusal analysis in orthodontics was just, with the chapter on it, was just published in 2024. It's already available, and the chapter that was edited by me is a part of this book right now. We're also working on the non-surgical maxillary skeletal expansion protocols chapter for the Elsevier with Professor Mernescu, and the US and Canada patent was filed for the guided midfacial skeletal expansion protocols in conjunction with the midfacial skeletal expansion. So the topic I'm focusing on today is the use of the midfacial skeletal expansion, which is the procedure that is pretty recent relative to the traditional orthodontic approach in expansion. And what I will be talking in particular today is the use of the midfacial skeletal expansion with so-called bone and tooth-borne skeletal expanders. And in our practice, where we do 90% of the adult cases, not only adult cases, so 90% of the patients who come to our practice, because we are airway oriented, we put a lot of effort into researching and clinical observations of the effects of skeletal expansion in growing individuals and in adults. And the protocol I'll be describing today is used in adults in non-growing individuals, which produces skeletal expansion. So the 5 main outcomes of the skeletal expansion in our experience are not limited to, but can be described as the maxillary width increase, the increase in nasal airway volume, which is an inevitable effect of the midfacial skeletal expansion protocol. It's the forward midfacial translation. It's more of an innovative outcome that is very limitedly described in the literature, and the septum spatial improvement, because the position of the septum is directly related to the increase in the nasal airway volume, and it is directly related to the position of the maxillary halves, and the facial lift effect, which is the skin effect, the effect on the facial tissues. So I'll be starting with the facial effects from the effects on the facial tissues, which are related to the bony, underlying bony tissue changes. So with the midfacial skeletal expansion and with the midfacial protrusion, what happens is we are observing significant changes in midfacial protrusion and in forward midfacial positioning, which results in most cases into correction of class 3 to class 1 and even in class 2. So the inevitable effect of the midfacial skeletal expansion, which is the maxillary skeletal expansion, is the change, is the movement of the whole midface forward, downward, and outward, which causes more fullness to the midface, which causes the whole maxillary complex detachment from the surrounding perimaxillary bones and sutures, and improvement of the facial skin profile. Another effect is the nasal septum position, and which is in particular interest is the protocol that we just recently developed with the use of the piezocortical guide. So the piezocorticotomy is an adjunctive procedure which is used to facilitate the symmetry of the maxillary skeletal expansion. And what it does, it is produced in conjunction with the placement of the maxillary skeletal expander itself, the appliance itself, and it's the piezocortical incisions along the mid-palatal suture. The way we modify this procedure is we are using a specific guide, which is individually custom planned and custom fabricated guide, which produces the specifically planned notches for the piezocortical incisions, and these notches are planned in relation to the position of the septum and the mid-palatal suture itself. So the point of introduction of this part of the procedure is to ensure that the nasal septum remains in the middle and it's not dragged to either side with the expansion and with the movement of the midfacial complex. One of the recent studies is showing a study by Dr. Liu was showing that even with the MMA surgeries, around 6.5% of all patients that underwent MMA surgeries, they still required any type of rhinoplasty, septoplasty, any type of nasal airway revision to improve their nasal breathing or for some other anatomical procedures. So this procedure in particular, the introduction of this piezocortical guide, which we have patent for in the US and in Canada, that improves the outcomes in terms of the symmetry of the nasal septum position. This is the outline and the pictures, the graphics of the incision that is made before the positioning of the midfacial palatal expander, and this is the location. This is the location of the suture. It's the suture and the incision itself along the palatal suture. And as you can appreciate, the numbers, in particular, the number 7, the figure 7 here in the picture, it points at the separation of the mid-palatal suture.
The main concern and the reason why I met Dr. Koval was because I saw her lectures on YouTube in regards to the issues that people have in terms of breathing. And all my life, I wasn't able to sleep. I would wake up at 3 a.m. or 4 a.m. in the morning, or I would only have 4 hours of rest. So that's why I came to Dr. Koval to be able to see if he was able to help me in regards to that. So what Dr. Koval recommended me to do was to do an expanded Marpi procedure, which I expanded up to 10 millimeters. And so throughout the entire time, I was expanding once or twice a day. So Dr. Koval recommended I do a procedure known as Marpi, an expanded Marpi procedure, which she expanded up to 7.5 millimeters of bone expansion and then 2.5 millimeters of molar tips. And by doing so, it greatly expanded over here horizontally. And over months that she recommended me to be able to do 1 key turn a day. Well, now I'm actually feeling way better than before. I can actually go to be able to sleep. It only takes me like less than 10 minutes to be able to go to sleep at night. I'm reaching deeper levels of sleeping. I'm having my full 8 hours. Also, I'm breathing much better. I don't have any more congestion at all. So I definitely recommend that anyone who has a breathing problem to go check out the idea of
So that was just the patient experience with the procedure itself. The main impact of the Marpi expander and the Marpi expansion is to improve nasal breathing, as was shown in multiple Stanford studies. Now I'm moving on to the third effect of the midfacial skeletal expansion, and as observed in our clinical experience with more than 300 cases, adult cases with Marpi expanders in particular, not the MSC cases. And as you know, MSC is the brand name for the appliance that was introduced by Dr. von Moon, while Marpi is more of an umbrella term, which is more of an individual custom design and can incorporate different types of designs. So one of the major effects that I would like to emphasize is the forward midfacial translation of the midfacial complex. And what happens is that multiple studies, not only our clinical observations with the CBCT studies, they are showing that the perimaxillary sutures, they are separating around the maxillary complex, and that causes the so-called squeezing forward and outward effect with the downward component. So there is also a relationship between the amount of expansion, and we are always, I want to emphasize that we're always talking about the separation, the bony separation of the two maxillary halves compared to increase in intermolar width. So here it's the amount of the bony separation between the two maxillary halves that determines the amount of forward midfacial translation. In our observation, any amounts of more than 7 millimeters, 7.5 up to 8 millimeters, and more, they cause some degree of forward midfacial translation. We've done cases where the patients were expanded up to 11 and 12 millimeters of pure bone separation, and as you see on the screen here, the midfacial, the pteromaxillary suture is also being separated. So pterygomaxillary suture is one of the most difficult sutures to separate, as it attaches it's the point of attachment between the base of skull and the facial skeleton. The effect, again, the degree of skeletal expansion, and I'm referring to pentagons, as I can schematically draw the skull itself in purple color, and in light blue, baby blue color, it's the midfacial complex. So the more expansion is produced by the midfacial palatal expansion procedure, the more there is a squeezing forward and outward effect of the midfacial complex and the forward movement itself. There was just a recently published study by Dr. Kim, and it's showing that the effects of bone-borne maxillary expanders, they do cause perimaxillary sutures to separate. And the most important part is that they have designed the study to compare the ATOS expanders, their proprietary expander, with the C-type expander. And what they showed that the degree of different suture separation was different, but there is. So these slides just show the position of the main sutures, and what they were showing is that frontozygomatic sutures, zygomatic and maxillary sutures, they were decreasing in their width, while the frontonasal, frontomaxillary, maxillary, nasomaxillary, internasal, intermaxillary sutures, so the sutures within and connecting the maxilla and kind of allowing for that separation, they were increased in higher degree, in higher amounts, compared to the zygomatic maxillary sutures and the front. So the sutures that are squeezed during that forward movement of the face. This is another slide from the same study showing that there is a distinctive separation in the sutures, and it is not referred to as a fracture. It's not a fracture. So the fracture, by definition, is the bone damage. It's the breakage of bone in the locations that are not supposed to be natural sutures. The suture separation is the act that happens in the sites of natural bony junctions, which are the sutures that naturally happen in the human's body. So once we observe those suture separations, they're not to be considered the side effects of the maxillary skeletal expansion or midfacial skeletal expansion. Multiple studies, one by one, are showing that these separations are the inevitable effect and are related to the degree of expansion and are related to the design of the appliance that produces this midfacial separation. One of the important effects is the increase in nasal airway volume, which was also shown in multiple studies. And what I want to draw your attention to is that one of the most commonly used measures of the expansion is the measurement and the increase in intermolar width. While the intermolar width is not an accurate determinant of the actual success of the expansion, the intermolar width is the reflection of the molar tipping more than, to a bigger extent than the bone separation. So there should be a more accurate component to measuring the expansion. And one of the components that has been recently used was the measuring of separation between the two halves of the maxillary bones, but also what contributes to the effects of breathing and airway resistance is the component that we've been measuring in our practice, and this is the distance between the medial pterygoid plates of the sphenoid bone. So that effect is the most important, because that effect relates to the position of the PNS. It relates to the attachments of two major muscles of the pharynx. So among the 6 major muscles of the pharynx, the salpingopharyngeal muscle and palatopharyngeal muscles are the 2 muscles that are directly attached to the posterior PNS, to the posterior nasal spine and that area. And the position of the medial pterygoid plates is something that has a direct effect on the lateral, on the width of the between the lateral walls of the pharynx, and as a result, the improved resistance of the airway. So here we see cases before and after, and we see that in some cases this distance improves significantly. From, for example, case 5, from 28 millimeters to 33 millimeters by almost 6 millimeters. Case 6 before and after 28 millimeters to 32 millimeters, almost 5 millimeters here. In some cases, there are lesser effect, which also depends on the amount of separation, the amount of the intermaxillary separation, and also depends on the design of the appliance and if the posterior nasal spine was actually separated. So in our practice, it's important to design appliances in such a way that the mid-palatal suture is separated all the way from the ANS to the PNS, avoiding any kind of the V-shaped expansion, ending up with a nice parallel expansion at every point. So this is just a growing individual in 13, 14 years old. She started with a crossbite, anterior crossbite, and bilateral posterior crossbite as well. So we expanded her 13 millimeters in the front, almost 10 millimeters closer to the middle third of the palate and closer to the PNS. So this is the drastic improvement in her airway volume, starting with the nasopharyngeal airway volume and the oropharyngeal airway volume just from the maxillary midfacial skeletal expansion procedure. So that allows us to conclude, and it's just the preliminary findings, that the midfacial skeletal expander, the expansion procedure itself, that causes, without any type of intervention on the mandible yet, that causes the improvement in the patency and the decrease in the resistance, the airway, upper airway resistance. One of the studies conducted in 2012 had 1,200 patients that were divided into age groups. And as we're constantly using the CBCT as an indirect measurement for the airway volume, and it's been constantly referred to, while it's not a golden standard for the airway, for the sleep apnea diagnosis or any type of measurements. But there were studies, and this is one of the studies that is showing the numbers, and the numbers are the total volume, total airway volume, and the minimum cross-section area volume. So each age is characterized by the average norms for the total airway volume and the minimum cross-section area. And it was shown that the airway dimension, the length, it increases from 6 to 12 to 20 years old, and that the total airway volume, it correlates with the smallest cross section, not with the length of the airway volume. It is important to note that the most critical is the choke, so-called choke area, which is the minimum cross-section area. And this area also increases while the patients grow, and that reaches its more or less defined dimension at the age of 14. So here, the same study, they concluded there is a reflection, or there is an association between the risk of severe, moderate, and mild obstructive sleep apnea with the minimum cross section, with the minimum dimension of that so-called choke area, and the risk of severe obstructive sleep apnea has correlated with the minimum cross section of 52 square millimeters and less, while moderate was related to 52 to 110 square millimeters, and mild OSA with 110 and more. There's also a relationship between the airway architecture and shape in different skeletal classes and different angle classifications. And we see that the skeletal class 3 has a more as a straighter profile, while skeletal class 2 has a more of a curved profile with more of a protruding due to the forward head posture. The angle classification, as you see, so we see a bigger airway volume in class 2 within the nasopharyngeal airway space, while there is less in the nasopharyngeal airway space in class 3s, and a little bit more in the oropharyngeal airway space. One of the major effects of maxillary width increase is of the midfacial expansion is, of course, the maxillary width increase. And what it says that that obstructive sleep apnea, and it was shown, is so that is one of the options of treatment of obstructive sleep apnea in adults as compared to DOME. The destructive osteogenesis maxillary expansion. So this is an alternative along with the DOME, as was shown by Christian Guilleminot and Audrey Yoon and Stanley Liu. It's a viable option for treatment of patients with obstructive sleep apnea. Now I would like to refer to some growth changes in the maxillary base, and why that matters is because while observing and while looking through scanning our CBCT scans, and we have to refer to specific norms. So these norms were taken from the studies by Ramnanda and from the atlas of the frontal cephalograms, and it shows that the maxillary width, in particular from MX to MX points on the anterior posterior cephalograms, it grows from 56 to 70 millimeters in females and from 58 to 76 millimeters in males. So if we're talking about a grown individual, we are looking at 72 millimeters of the maxillary base width in females and approximately 72 to 76 millimeters of maxillary base width in male patients. This is just the graphic representation of how the maxillary base width increases with age from 5 years old to 18 years old. And this is the changes in the maxillary base from midline to the point MX. So we're looking at the increase from 27 to 36 in females and males. We're also looking at the interzygomatic points. So when we do maxillary expansion, there is a broad discussion on how the interzygomatic width changes with the midfacial expansion. The ideal proportions for the grown individual is 135 millimeters in males and 126 millimeters in females. Same thing if we are measuring the same width, the same dimensions from the midline to the one of the points, it grows from 53 to 64 in females and from 54 to 66 in male patients, and it reaches its final finite dimension at the age of approximately 18 years old. This is one of the most important. This is the nasal width measured from the most lateral point of the nasal aperture to the most lateral point of the nasal aperture on the other side, and we're looking at 32 millimeters of nasal width. In ideal world, the nasal width has to be the same as the nasal base, and when we are diagnosing for the maxillary deficit, we are measuring the MX to MX distances that I was just describing, and the nasal width as well, which should correspond to these numbers, 32 in males and 30 in female patients. So now I'm transitioning to MARPI and shape memory aligners, and shape memory aligners have almost replaced any type of other aligners in my practice, and because this is an opportunity to custom design and custom planning of the aligner treatment in conjunction with MARPI. MARPI is done for aesthetic reasons. MARPI is done for wellness reasons, for improvement of the nasal breathing. And of course, one of the major parts here is to plan the aligners accordingly to be able to control the roots, to be able to move the roots along the midline, and to be able to close that gap efficiently. And the shape memory aligners are the aligners that are directly printed in our in-house lab with the graphy material, which is the graphy resin. And the treatment, the sequence of planning and producing, it depends on the expansion amount. It depends on the, we do take facial scans with our CBCT machine. We do position the nasal, the incisors and the incisor roots according to the superimposition of the facial scans and the CBCTs, because the CBCTs itself, it does not give the accurate information on the relationship to the smile. So there should be some kind of a superimposition between the actual facial profile and the bone, so that we can plan accordingly. Because the main point, and is the aesthetic area, we have to plan that the midline is right where it belongs. So this is the effects of the closure. And as we know, with the midfacial expansion, you were able to appreciate that we get a lot of bone separation. And what happens there, this is the area where we get a lot of we just get an empty space which is filled with the connective tissue, and which has to gradually solidify and be replaced with the newly generated bone along the suture connections position. So this is the area where we have to be extremely careful with not forcing those roots into the expansion space, and be able to gradually tilt and tip the crowns of those teeth, and to then follow with the roots. So the type of movement highly depends on the amount of expansion. And if we, for example, expand less than 5-7 millimeters, which is which still produces drastic wellness effects in terms of nasal breathing, we do have a specific protocol with less tipping and with more aesthetic outcomes in terms of more parallel incisor movement. So the shape memory aligners and the material that we use, the graphy resin, this allows us to reduce any need in attachments, in additional bonding and removal and polishing of tooth surfaces, while the resin produces elasticity levels and the physiologic levels of force that allow for very efficient, within almost 3 months, closure of that interdental space produced by the expansion. So this is one of the cases treated with the shape memory aligners with the resin by graphy, and we expanded this patient by 11 millimeters. And what happened is that the patient asked us for aesthetic purposes to cover the space with some temporary composite. And what we were doing, we were just gradually shaving down that composite and closing those gaps. And you can see this is just the effect of almost 3 months of closing, and he still does have some composite left, but this is how the aligners, the shape memory aligners look from this is the maxillary occlusal view, and how the gap progressed, and how it was continuously being closed with shape memory aligners. And this is how the actual planning happens. And we do this with the NemoCast, NemoFab software from Nemotech, from the Spanish company. And this shows us some buildup of the composite that was used to camouflage that gap temporarily. And this our software that allows us for all 3D plane planning of the tooth position, of the root positions, and the relationship to the this midfacial separation. This is the process of actually producing the shape memory aligners. We do have printers. We do have several printers in our lab, and this is just a few studies by Dr. Kim from St. Louis University, the chair of the Department of Orthodontics and Dentofacial Orthopedics, that has been conducting studies on the efficacy and the accuracy of the resin. So what those studies show is that the direct printed aligners produce physiologic levels of force within the range of 0.8 or 1.5 newtons of force, which was shown by William Prophet as physiologic levels of force that are well tolerated by the body. While the thermoplastic aligners that are used with the regular, third-party aligner producing companies, those aligners, they produced way higher forces that may sometimes exceed 5, 8, 7, 8 newtons of force, which is almost 5 times higher than the physiological levels of force. So this is just a video that's showing me, and we have printed this aligner with increased thickness, and that shows that we can modify the design of those aligners and add any additional features to that. And in this case, we just added so-called precision wings, and this is the maxillary part of the aligner. So that part will serve as a part of the functional appliance to produce the mandibular movement.
And this is the easiest way to put it in my mouth.
So as the aligner, this material is thermoplastic, it depends, the plasticity of the material depends on the temperature. The material can be easily molded and with the higher temperatures, and once it reaches the temperature of the mouth, it gets more rigid, and this is when it produces its effect. So it's just also a 1 month effect of the direct aligner application. This is how efficient they are, and this is the facial effect of midfacial skeletal expansion. This is how drastically face changes with improvement of the skin architecture, with the nasolabial folds and the position of the mandible. Of course, you see the facial proportions, they change significantly, and what I want to thank Professor Constantinescu for allowing me to present here. And these are my mentors, Dr. Stanley Liu, Dr. Von Moon, Dr. Kenji Ojima, Dr. Richard Ting. I am grateful and honored to be able to present here. Thank you very much for this opportunity. You can find me on Instagram, on social media, and this is the website that shows what procedures we.
Dr. Koval, thank you so much for your presentation and for your contribution in Elsevier book project. Thank you so much.
Thank you very much. I appreciate it.